Let's go on to the first lecture. The first lecture is about endovascular therapy of stroke. Big news, right? Everybody's talking about this nowadays. I bet a lot of you know that I have been very outspoken in the past about TPA for stroke. Really? Just a little, just a little. And we're not going to talk about that now because it's a whole other topic and a little too big. But just as background, you know, we've been told for some time now, since the NINDS study, NINDS, was published in late 1995, that this is the best thing since sliced bread, and it really cures stroke, and it's a great thing. And, you know, I'm pretty sure the evidence shows just the opposite, that it doesn't work. And we've, in this course, gone over that many, many times, all the evidence about this. Now, the new kid on the block is no longer TPA, it's now endovascular therapy, mechanical removal of the clot itself. Based on the same theory, there's an acute clot, you get rid of the clot, you're going to make everything better. And the theory is a little more complicated than that even. It's that there's a little area where there's already infarct, you can't do anything about dead tissue, but surrounding it is this penumbra, this shadow of still vibrant tissue, but that will die if you don't do anything about it. You get rid of the clot, it will now be better. That's the notion. And that's very similar to the notion of thrombolytic therapy for heart attacks, right? Heart attacks, acute clot, you get rid of the clot, it'll do better. And we know that thrombolytic therapy for heart attacks does work. And we also know that mechanical therapy for heart attacks works even a bit better. But let's be clear about that. For heart attacks, it's not most heart attacks, a very small number of heart attacks, only a STEMI. And with a STEMI, only if you get it early. And how well does it work? It works about the same as a single aspirin. It works a little. It's additive to an aspirin. The two together is better, but it's a very little. It's not a lot. And there's lots of reasons to believe that it would work much better for the heart than it would for the brain. So it's not likely to be great. Theoretically, it's not likely to be great. The other thing is mechanical therapy is better than TPA for the heart. But the difference is teensy, weensy, weensy. It's about 1%. So the notion that getting rid of it mechanically is going to be way better, also, theoretically at least, doesn't make sense. Now, a lot of times I spend a lot of time criticizing theory. Just because it sounds right doesn't mean it is right. So we've got to go to look at what the evidence actually says. We'll do that. But just want to, as a thought, remember that this is not great stuff. It's a little stuff. Even in a heart attack where there's much more time to save the heart than there is to save the brain. And mechanical stuff is not very different than systemic stuff. The minimal difference. Okay, so the background now, for the last 20 years, we've been arguing about TPA. And there are big advocates of TPA, but the best that anyone can claim is a very, very marginal benefit. Very, very, in a small bunch of patients with stroke. That's the best you can claim. I'm pretty sure that that's way overstated, that it actually doesn't do well at all. It doesn't do anything good. So along comes this mechanical therapy, and that's what we're going to talk about now. And by the way, I know that the horse has left the barn. I don't think we're going to get it back in. So this is for us to think about, not because we should go to the barricades and fight it, because I don't think that's going to happen or is possible. But I am worried about what's going to happen as this therapy gets more and more widespread. Because right now it's not widespread because there aren't people to do it. But you're all going to be asked to send people, stroke patients, from wherever you are to the nearest place that has somebody who can do it. There's also going to be much more time and money and effort spent on teaching people how to do this type of work. Teaching radiologists and neuroradiologists how to do this type of work. And the first two articles in here, which are written by advocates of this therapy, say it is a world changer, it changes everything. We have to change our whole medical system to accommodate this. That's what the two articles say. And I'm not going to review all the details why they say it, but they go over the literature a little bit, which we're going to go over now. They acknowledge that all the initial studies were very negative, but now there are a few positive studies, and we shouldn't believe the negative studies. We should only believe the positive studies. And because the positive studies are there and it is positive, this is really important, and we should now change our whole EMS system, our emergency departments, and our neurology approach to stroke based on this. So that's That's what's now being written. Those two articles are fairly recent, and they're in big journals, and those are the claims they're making. So we're going to talk about that for the next few minutes. So I will remind you, those of you who have been following the TPA debates for stroke, that one of the things that advocates of TPA claim is that all the relevant literature is positive about TPA. Whereas if you actually look at the 13 or so trials, there are only 2 of them that even claim to be positive. And one showed a little benefit, and one showed teensy-weensy bit of benefit. And when we reviewed the actual raw data on the most positive study, the NIN study, we found that it wasn't positive at all. So in fact, I believe that it's universally negative, the information, and yet the claim is that we should ignore the negative stuff and only the positive. And it turns, so I just want to make the same point again. It's really not hard to claim for any therapy that everything we know about it is positive, as long as we voluntarily ignore everything that's negative. And there's always a reason to ignore it. So with TPA, for example, it was the wrong timing, it was the wrong dose, it was the wrong drug, streptokinase isn't as good as TPA, which clearly is not true, by the way. But although if you just find a reason to ignore unpleasant information, then the world's a very happy place. Everything you read is positive, because that's all that's left. So that's what the first 2 articles state. They say, yeah, there was all this negative information, but it's irrelevant. Only the positive information counts. And when we do a meta-analysis, if we only look at the positive information, my God, it's positive. And so that's sort of really disordered thinking. And science tells us that you should never ignore other information. Some information is not as good. Some we should put less credence on if you had a really good reason to do that. But if you just start out with anything that's negative, we find a reason to throw it in the trash, of course you come up with rosy-eyed view that's unrealistic. So let's go over the evidence. There's more papers in the world than in here, but this is most of what's out there. This chapter includes most of what is written so far on this therapy. So the first 2 say it's wonderful and we should change everything. What's the background? So the next couple of articles are reviews of the early studies of mechanical therapy called endovascular therapy. And the first one is the first large series that was published. Neither of these are randomized trials. The first is a large series, and the second is a review of all the studies that have been done up until that point. None of them were randomized. The first one, which was done at my institution, UCLA, where they're tremendously big advocates of this type of stuff, had horrible, horrible results. And unlike the positive studies, of course, it wasn't published in the New England Journal or JAMA. It was published in a lesser journal. And what's more, even though I was at UCLA, I didn't even know this article was published until a year after it was published. And I had been asking them for a long time, what's your data show? And they never told me. And a year after it was published, somebody pointed it out to me. I went to look at it, and you have there the results. I'm not going to go over them, but they're terrible. The outcomes were awful, almost universally. 1/3 of the patients treated with this therapy were dead. 1 out of 3. There was no sign of any good neurologic outcome. It was a complete disaster. One other thing to just mention is that the good outcome that they measured occurred in very few patients, but it was not the same good outcome that we had been talking about when we were talking about TPA for stroke. So with TPA, there's this thing called the modified Rankin scale, which goes up to 6. 6 is dead, that's not so good. 0 is normal, and then everything in between. Well, for NINS, the most famous study in the world, a good outcome was 0 or 1. 0 is normal, 1 is you're basically independent, doing everything great. And we got used to numbers of something like 30 to 40% of patients, with or without TPA, got one of those good outcomes. So that's the number you're sort of used to reading. Well, in this study, it was it was just under 30% with a good outcome. So it didn't sound all that bad until you realize that the good outcome definition was changed. It now included 2, 0, 1, and 2. 2 is much worse. 2 is substantial deficits, but you still can be independent. So in NINS, if you include it up to 2, you're over 50%. So less than 30% is a lot worse than 50%, although it sounds pretty close to 30%, right? So just by changing the definition, if you don't look carefully, if people don't go into the details, it sounds like it's not that bad. But actually it was way worse than the placebo group in NINS. And in all of these subsequent studies, the definition is now changed to include this lesser outcome as a good outcome, which makes everything look better. So that's just something I want you to keep in mind. So this study was terribly negative. The next one was they looked at all 23 studies, trials, where they used this drug, where they used this treatment, the mechanical treatment. And 23 studies, only 300 patients. So a tiny, tiny, tiny number, right? And what did they find? Same thing, a third of them dead, terrible outcomes, even using the 0 to 2 score. One other thing they found was that there were 298 patients total, but they could only look at the outcomes in 147 out of 298. Why? Because the manufacturer refused to tell them about this 151. So my guess is that those 151 where the manufacturer refused to say really had great outcomes. I don't think so. So this is pretty terrible. So imagine for a second you have a new treatment. It's killing 1/3 of the people. Nobody's doing well. And that's not even looking at the half of them where it's so bad they won't even tell us. So what's an appropriate response to that? More study. If this were the other way around, if the first 200, 300 was fabulous results, would they want to be doing more studies? What would they say? It's unethical to study this. It's proven. It's great stuff. Well, they didn't say that. They didn't say it's unethical to keep doing this and killing patients. And by the way, I worked at UCLA where this was done, and these patients were very carefully selected, and most patients were refused because they were sick. So the results are even worse, okay? Despite that, they continued to study it. But they had an excuse. These studies don't count. And the reason they don't count is because the device that they were using wasn't good enough. And they have a new device, and it's better, and therefore the results will be better. And that's sort of astonishing to imagine, because although they don't tell us in most of these articles what happened with this device, in the one where they do tell us, 85% of patients had perfusion restored. You can't do better than that. So I don't know what's better about the new device, but it's hard to imagine how it could be any better. If the way it works is by restoring perfusion, and the old device restores perfusion in the vast majority, then it's hard to imagine that a new device is going to be better. Despite that, they soldiered on and started to do other studies. So, I left out, they then did 3 randomized trials with the old device. And those were all published in 2013. And they're the next 3 articles in here. I don't have the numbering, but I think it's 5 to 7. One of those is also from UCLA, 3 in a row. And what did they find? Same thing, terrible results. Randomized trials, no better or worse than the group that didn't get it. And lots of deaths and really bad overall outcomes. And no advantage versus non-use. In fact, worse in one of the studies. So you would think that would be enough, right? But no, it wasn't. They went on. They said, no, we have a new device. We're going to study it again. So that's sort of already a little bit scary. But in any case, let me see if there are any of the numbers here I want to tell you about. Other things. They looked at whether or not a favorable pattern on the MRI predicted outcomes. So what's a favorable pattern? It means I see a clot, I see a small area of infarct, but it's only small. I see a large area that's ischemic but not yet infarcted. It's in a big vessel where I can easily go in and get it. Everything is good. And favorable outcomes favorable situation did predict better outcome. If you had the favorable situation, you did better than if you didn't. But actually, that was true in the group that got the clot removed, but it was also true in the group that didn't. In fact, it was more true in the group that didn't. So what does that mean? If you have a favorable circumstances, and it's better if you pull it out, but it's also better if you don't pull it out, what does that mean? It means that this is a marker of you're less sick if you have those circumstances. If it's already a lot of dead tissue, of course you're going to have a worse outcome. It says nothing about moving the clot does anything good. In fact, it suggests that that's irrelevant. So this is a marker. It's the same way if you have sepsis and you have a very high sugar, that's bad for you. But you don't get better if you treat the sugar. It just means that you're really sick, and therefore you're putting out a lot of insulin and you're putting out a lot of sugar. So in the same way, this is a marker of how sick you are. It says nothing to do with the theory of, oh, that's good, we'll get rid of the clot. And by the way, in all the TPA studies, they always found the same thing. That whether or not you got rid of the clot didn't matter. What it looked like before you did the treatment is what mattered. Okay, so with that all in mind, there are these 3 negative studies. And again, that didn't persuade anybody. They continued to do studies. So then, in early 2015, in the same issue of the New England Journal, they published 3 other randomized control trials with the new guy, the new clot remover. And these, unlike the first 3, were universally positive. They all showed benefit. Oh, by the way, in the earlier studies, the methods that are reported in the New England Journal, because they also were published all in one issue of the New England Journal, in those 3, they don't really tell us what the control group treatment was. It seems like most of the patients in the control group who didn't get the endovascular therapy got TPA. But in one of the studies, there's a suggestion in the methods that a lot of them didn't. So we don't really know what the controls were. In these 3 later studies, the ones that are positive, the new ones that are positive, we do know what they got. There it's reported, and all of them got TPA. So this is comparing TPA with nothing versus TPA with the device. So we have no studies which compare it to don't do any of that stuff. Okay, these 3 studies are all positive. What's interesting about them is that despite that, they have very different results than each other. So in one of the 3, the control group did really well, but the device group did even better. In one of them, the control group did terribly, and the device group did terribly, but just not as bad as the controls. And the third one somewhere in between. That's sort of a little bit hard to understand if this is a magical therapy, why in one of the studies the results are miserable. Because basically, while there are small differences in their design, they're very, very, very similar. So they're all over the board there, but these 3 are positive. And if you ignore the negative ones, then everything's positive. So that's where we stand. That's basically what we know about this. There are 2, those are also in your manual, and then there are 2 other studies afterwards which I've also included in here, which you can look at, which also tend to be positive. There's only one of the studies where the positive group is a little better than the NINS TPA group. There are some where it's miraculously better and some where it's way worse, but always better than placebo or the control group. There's one where it's a little better than TPA. So what does this all mean? So if you ignore the negative stuff and you say the new device is the truth, it's better. It's good. That's one thing. But I don't think it's appropriate to ignore the negative studies. You put them all in there, it's not clear that it's any good. It also doesn't make sense that the new device is a lot better. Why would it be a lot better? It can't be a lot better at reperfusion because the old device was awfully good at reperfusion. So how did it do so magnificently better? Why is it so magnificently better than TPA alone? Because remember, in heart attack studies where there's huge amounts of information, the difference between PCI and TPA is about 1%. So it doesn't make sense that in stroke it would be magnificent compared. So there are a lot of reasons to think maybe this is a little bit, it doesn't make a lot of sense. Two other things I really want to say, and then I'll stop. One is, there's one other little thing that I studied these studies carefully. I looked at their appendices and tried to figure out what was going on. Something I missed until it was published last year in September in an article in the European Heart Journal, where there's one other piece of information that I hadn't realized that I'll just tell you now. The biggest difference between the old device, which didn't work, and the new device, which works not a little, but it's fabulous, supposedly, the biggest difference is not in the outcomes in the people who got treated. It's in the outcome in the people who didn't get treated. The control groups with the old device had about had 42% of them, 39% of them, 32%, I'm sorry, 32% of them without treatment had this good outcome using the new definition of 0 to 2. That's pretty miserable, but it was 32%. With the new device, where the new device was much better than controls, the control group had 22%. That was the big difference. The difference between the good outcomes with the old device and the new device was 4%. The reason it looks so much better is because the control group was so much worse. Let me say that again. It's not that the new device had better outcomes than the old device. It was a little bit better. It's that the new device was being compared to a much worse comparator. So it looks way better than the control group, whereas the old guy didn't look better than the control group, even though it didn't change at all. All that changed was the control group. That's pretty stunning. This is all based on ignore the old bad results because the old device is no good. The old device did just as well as the new, almost as well. One other thing that's more important than any of that. So I personally, I don't know the truth. You know, when we first started critiquing TPA in the late 90s, I said, I don't know the truth, but I don't believe it. There's a lot of reason to be skeptical. And then over years, we got more and more and more and more information. And I moved from, I don't know the truth, to, I think I know the truth, to, I'm pretty sure I know the truth, to, this doesn't work. I'm sure. Okay? The more information we got. So with this stuff, I'm not sure. I don't know the truth. But I certainly am not ready to believe that it works. And I certainly do not believe it's magical. But there's one other thing that's really, really important. Who qualifies for this treatment? So according to the studies, here is how you got included. You had to have a large clot identifiable on advanced imaging. It had to be in a big vessel in the internal carotid or the proximal middle cerebral or anterior cerebral. No posterior circulation stuff, nothing. Just a big clot that I could see. There had to be only a small infarct size. There had to be a large ischemic penumbra. There had to be good collateral flow. All of that was required. How many stroke patients have that? I don't know, because they don't tell us. All of the studies, only one of them said how many stroke patients did they have to go through in order to find patients for the study. In that study, they went through 7,700 stroke patients to get 70 who qualified. 1%, just under 1%. So, if this works, and again, I don't know that it works, I can't say it doesn't, but I have lots of reason to be skeptical. But if it works, they want us to change the whole EMS system for this and to start training lots and lots of people to do this, spending our money not on sepsis or heart attacks or things that are common, not on that, not on homelessness. They want us to spend the money on this, where 1% of stroke patients might qualify. And of those 1%, if the best estimate you could imagine from this stuff is that 1 out of 3 would benefit, so it means 1 out of 300 stroke patients would benefit. How many stroke patients benefit from an aspirin? About 1 out of 900. So this is a little better, if we believe all the positives and none of the negatives, it's a little better than an aspirin. We should change the whole world for it. It's pretty amazing. Now, what's really going to happen, and this is the last thought I'll leave you with, a cheery thought. If once the people start doing this, and they do change the world, because they're going to do it, right? It's a big moneymaker. And it's more than a moneymaker. It's something, I can do something about a stroke, which a lot of people are desperate for because it's a bad disease. So we like to believe good things about something important, regardless of what the evidence is. So anyway, if that happens, do you think they're only going to do it in these people who have those particular conditions, that 1%? Something called indication creep, which means we prove that something works for condition X when we have this very narrow limits. But then we start expanding the limits. Anybody seen that happen with TPA? We started out with 3 hours, and there had to be the right blood pressure and the right age and the right exclusion criteria. I've had to review a lot of legal cases against people for not using TPA, and the plaintiff's expert routinely says things like 6 hours doesn't matter. We do it 12 hours. We do it 22 hours. We do it even if the blood pressure is uncontrolled. We do it age. Why should age? That's age discrimination. There's indication creep everywhere. So if this works, it's for a tiny, tiny subproportion of stroke patients. And would it work if we started doing it in 10% of strokes, 15, 20? Would the harm outweigh the benefit? That's what's going to happen, for sure. I mean, almost for sure, right? So that's the only thing and you will be accused if you don't do it. So that's what I want to leave you with, is think about that. Again, I don't think we have this, we're going to fix this. I think it's a fait accompli. But at the very least, we should try to insist that if they're going to do it, they do it under these very, very narrow defined conditions where there's at least some evidence that it could be useful.